Okay, so I'm going to give you some pearls about bicruciate retaining knees. And I am a consultant for Smith Nephew, OrthoGrid, and also VR, but this is a passion project. I started working on this knee design in 2004 because I'm 55 and I have knee arthritis and I still have my ACL. And I also believe that bicruciate knees can be successful. The Townley knee showed 89% survivorship at 23 years. This is a first generation knee implant with not cross-linked poly with cobalt. So I think we can do a good job. So if you understand your indications and you have a good implant and use intelligent technology, you can have success. The indications are what you'd expect. Someone who has medial compartment arthritis or lateral compartment arthritis combined with patellofemoral disease, more than what you would consider to do with a unicompartmental replacement. And this is a nicely executed bicruciate sparing knee. And this is the patient at 12 weeks post-op. So you can get incredible range of motion, great stability, and more importantly, you preserve proprioception. So when I look at indications, I'm looking at four things. How much deformity do they have? As indicated earlier, if someone has more than 10 degrees of a varus deformity, they're likely to have an insufficient ACL. So of course, they have to have a good ACL. A flexion contracture tends to be a problem, especially if you have to start moving your joint line. And I want patients for a BMI under 35 because of the stress on the tibial plate, and they should have good bone stock. So a typical patient, this patient is an active pickleball player. She has medial compartment arthritis, pretty severe patellofemoral disease. This is her bicruciate retaining knee, and this is her 6 weeks post-op. And larger, this patient is a BMI of 35. Stiffer knee. In this patient, we decided to do a bicruciate sparing knee. And again, this is his postoperative x-rays. This is him immediately postoperatively. And this is him at 6 weeks post-op. So the question is, do you need an MRI before to assess the integrity of the ACL? And in patients who have a big varus deformity and the ACL is worn, they'll have this posterior pattern of wear. If the knee is sitting where it belongs, the femur over the tibia, then they typically do have a good ACL, and I rely on my clinical exam. So red light contraindications, be wary of large deformities, especially significant lateral tibial subluxation. A large flexion contracture is definitely a no-go. I'm cautious with patients with BMI over 35, and bone stock has to be good, particularly on the tibia side. I would not use this as a bailout or a conversion from a uni. So this patient had an ACL reconstruction, and I really wanted to do a bicruciate sparing knee, but this is a non-anatomic ACL reconstruction. The knee was unstable in rotation. So we did a bicruciate substituting total knee replacement, and she's done very well. So implant design is important. We've had some spectacular failures with bicruciate sparing knees in the past. And the Journey 2XR is total knee resurfacing. And I love what Professor Howell was saying about restoring pre-arthritic anatomy. This is an anatomic prosthesis. It has a larger radius of curvature medially and a smaller radius of curvature laterally. It's based on MRI and CT data of 10,000 knees. The tibia was designed, it's made of titanium, so it transmits stresses beautifully to the bone. And it has this keel, which gives it stability like an I-beam and strength and good bite and fixation in the tibia. The tibia surface will drive the motion somewhat. It's concave medially and convex laterally like a normal knee. You can see that in the implant design. So this combined gives you this oblique joint line, which is physiologic and anatomic, and keeps the femur located directly over the tibia, and it rotates. As you go in and out of flexion, you have this nice rotation that normalizes ligament tension and enables deep flexion. Now, you have to put this implant in precisely, and the implant is less constrained than a typical total knee. It's not a ball and socket type knee. It's really ligament-driven motion. So if you move the joint line proximally or distally, you have abnormal tensions on the ACL and PCL, and you'll have a very stiff knee. And you want to balance it medially like a medial uni, so 2 millimeter gaps in flexion and extension. And laterally, balance it like a lateral uni, where you have 3 millimeters in extension, opening up gradually to 7 millimeters in deep flexion. So you are looking to create that oblique flexion gap Professor Howell had mentioned. And I need a computer to do this well. I started doing this without a computer in 2014, but I found it challenging to get consistent results. But now I use computer-aided design that lets me prototype my decisions before I make any bony cuts. I use dynamic gap balancing with a tension gauge, so I know exactly my gap tension throughout. And I execute my plan precisely with robotic-assisted bone milling with a handheld CNC machine. So typical case, this patient is 47, he's 6'4", and he's a basketball player, and he works on the dock on the tugboats. His knee has primarily patellofemoral disease, but he also has tricompartmental disease, so patellofemoral replacement alone wouldn't do it. His major issue is his trochlea dysplasia. I do not use a tourniquet. I do everybody through a subvastus approach. I think that helps with recovery. When I do my approach, think of it like a uni. You don't want to do a very large ligament release. You want to do minimal ligament releases, but you do want to remove the osteophyte so you have good sizing and planning for the robotics. The robotic systems, like the navigation system, use infrared trackers. We put our femoral tracker within the wound, the tibia tracker outside the wound. We define the center of the ankle by touching the medial and lateral malleoli, and a 60-40 split between the two is the center of the ankle. Center of the knee is at the center of the ACL footprint and the terminus of the trochlear groove. We can collect this with a point probe, and then we rotate the hip, and this will give us the center of the hip. So with all this data, we have the mechanical alignment of the limb, and I can dial it in. I tend to undercorrect the alignment slightly, but I want to stay within 3 degrees of neutral to optimize wear. We define the initial range of motion. We do this with a slight axial load. So all this takes very little time. We do image-free mapping. So this is tracing the outline of the femur. We have a database of CT scans. It brings up a mesh shape that's about the same size and shape of your knee. And now you're just coloring in and reproducing the cartilage surface of the knee that you're working with in real time. It takes about 40 seconds to register the knee. A total knee replacement for me takes 45 minutes with this technology. I'm faster with the robot than using manual instrumentation. The tibia is registered the same way, but I make some special points around the ACL footprint. And we're going to slightly internally rotate the tibia tray to match the ACL footprint rotation, just like a uni. And now we have initial implant placement. And in this case, I really want to reproduce the patient's pre-arthritic anatomy. I'm looking to match the joint line on the femur, match the posterior offset. I am not aggressively externally rotating the femoral component. I want to match the posterior condylar axis so I have that oblique flexion gap. The tibia, again, is matching the less affected joint line, and rotation is important to match the ACL footprint. Tibia base plate has to get good coverage and good positioning. And then we can stress our gaps, and we do this with a tensor gauge now. So we now have a gap assessment throughout the full range of motion of the knee, and we can fine-tune our implant to get the exact balance the way we want it. And we have information at 0 and 90, but also throughout the full range of motion. So in this case, I was a little tighter laterally in extension for this valgus knee, and I made a decision I'm going to not do any releases. I'm going to do my knee and see what we have. We're removing the bone here with the CNC machine, and you can see we're not aggressively externally rotating that femoral component. We have very precise bone preparation. We can remove the bone for the tibia component with this milling technique. And you can see here that we're using this CNC machine to mill out the space for the keel. We have plenty of exposure. You can get to the back of the knee very easily, and you can see an actual implant, and there's plenty of room for the ACL and PCL. We can then import our trials and do an assessment of our gaps. And in this case, the IT band was giving us a little bit of tightness, so we did a pie crusting technique, and we improved our alignment and our extension. This is the case information, so we have an integrated database with our cases and our outcomes. Intraoperatively, full range of motion quite easily. You can see this is a bone-conserving prosthesis, really a total knee resurfacing. The femur is sitting where it belongs, right over the tibia. We've maintained our oblique joint line. This is him going home the same day. For me, 75% of my patients go home the same day for primary knee replacement surgery. This is him at 4 weeks post-op. And these patients recover very much like a uni and require very little in the way of formal physical therapy. So this is one of the reasons we love this implant. So this is a challenging patient. This patient is surfing very high level and he wants to continue surfing, and he's failed all our conservative management. Do I have a surgery that I can do for him that will let him perform at the high level that he's expecting? This is his plan. And again, we're restoring pre-arthritic anatomy. In an area where he has cartilage loss, we are putting extra implant back. We're matching his cartilage surface in the area where there's normal architecture, and again, matching the joint line. This is his surgical x-ray. This is him the same day going home with 135 degrees of flexion. He's back surfing. So he has great flexion, so he can pop up. He has great stability, so he can surf, and great proprioception. I think if you have good indications, an excellent implant, and intelligent technology, you'll have great success with bicruciate sparing knee replacement. It's my favorite procedure and draws a lot of patients to my practice. This is part of a family of implants, and there's a bicruciate substituting knee, a CR knee, which retains the PCL, and the XR, which retains the ACL and PCL. I would say I'd rather have a perfectly done bicruciate substituting knee than an XR where I was concerned about the quality of the ACL. So I'm critical about the ACL until the very last moment. It's easy with the robot to change implants. Our patients have high expectations. We have amazing implants out there that have a very high tolerance. So we have to make sure we use technology to do it and improve our accuracy and precision every time. Thank you very much for your attention. I really appreciate the opportunity to participate in this conference.